presentation. I'm sure it will really help us to have some more hopeful outcome for our patients. So now coming to Dr. Joan Young. She's completed her medicine from the University of Dundee. She's a senior research associate and at Maternal and Fetal Medicine, University College London. She's done her medicine from University of Dundee. She's done her MRC PH and then Paediatric Neurology from Great Ormond Street Hospital. She's done her PhD in gene therapy from UCL London. Her research interests are in neurotransmitter disorders, movement disorders. She's got an award from the British Society of Gene and Cell Therapy Fairbrain Otto Wolff Neuroscience Symposium Prize in 2016. She's a lead in the preclinical gene therapy development for childhood neurology disorders. Over to Dr. John Young.
Great. I'm just going to share my screen. So can you all see my slides? Hello?
Yes, we do.
Great. So it's a real pleasure to speak to you guys today and join you from London. So I guess my link to India is I've worked with many Indian trainees, and it's always been a real pleasure to work with them in London. My husband is from Goa, so normally I am able to travel to Goa every year. So I am really missing visiting my in-laws in Goa. I'm missing the food due to the pandemic. So I'm going to talk to you about gene therapy in pediatric neurology. And these are my disclosures. So the outline of my talk is really to introduce you to viral vectors, because I appreciate this is very much a clinical audience. Tell you about the clinical delivery routes and highlight some key clinical gene therapy events that have happened in the last few years. And just a whistle-stop tour of our efforts in developing gene therapy for dopamine transporter deficiency syndrome. So genetic therapies, they are the cutting edge of new precision medicines. And I think most of you will appreciate that millions of people have received a genetic medicine this year. So if you think about your COVID vaccines, these are genetic medicines. Covishield is a viral vector-based vaccine that delivers the spike protein DNA of coronavirus, and the Pfizer and Moderna vaccines are mRNA-based vaccines. So most of you probably have received a genetic medicine this year. But specifically for childhood neurological disorders, there's a different approach. The aim is really to correct a genetic disorder. And that really is through gene supplementation at the moment for the clinically applicable gene therapies. There are newer technologies that are looking at gene silencing. So if you've got a toxic gain of function mutation, gene upregulation in haploinsufficiency disorders, and then more precision medicines where you correct the mutation through genome editing, base editing, or even prime editing. But these are really very new technologies. So gene therapies really reaching the clinic are using genes as a medicine. So we're helping to correct genetic disease by providing a functional gene to the patient. So this is what a gene therapy might look like. You have a promoter and a segment of DNA, which is your gene of interest, the gene that's going to be the treatment. And we use viral vectors to deliver the DNA. So the viral vectors are our messengers. And there are lots of different viral vectors that we might use, and it really depends on the disease application that we're approaching, on which one we decide to use. The most commonly used viral vector in child neurology is adeno-associated virus. So it's this tiny virus here. It is the smallest virus, and it has the best safety profile. Being small means it has a limited packaging capacity. So it can only package 4.7-ish kb of DNA. So it limits the size of the gene that you can deliver as a medicine. Other ones we use in child neurology are lentivirus, but I'm going to concentrate solely on adeno-associated virus. So this is what adeno-associated virus looks like. It's not a COVID, but lots of people might think it is a COVID. And I want you to think of viral vectors as envelopes. So you have an envelope, and within it is the viral DNA, so the viral message. What we do as gene therapists, is we take out the viral message and we just leave the envelope, the viral capsid, and put in our gene that's going to be the medicine, that's the gene therapy. And we use viruses because they're so good at infecting cells. So we have our gene packaged in the viral capsid, it's delivered to the cell. And then the virus gets to the nucleus of the cell. The viral coat is disassembled, and then you have the DNA delivered beautifully to the cell. It undergoes transcription and translation, and then the cell itself produces a therapeutic protein. So those are the principles of using a viral vector to deliver DNA as your medicine. So there's lots of different AAVs around. So there's naturally occurring AAVs, so they're numbered generally. These are the ones that have been used in the clinic, specifically for neurological disease. There have been clinical trials in AAV 1, 2, 5, 6, 8, 9, and rhesus 10. But there are also novel AAVs that are being developed in the lab, so they're synthetically modified. So there are literally hundreds of AAVs, but these are the ones used in the clinic at the moment. The clinical delivery methods, there's lots of ways to deliver AAVs. So you can inject it directly. So you can inject it into the eye to treat eye disorders. So Luxturna is an FDA-approved gene therapy for retinitis pigmentosa. For childhood neurological disorders, you can inject it directly into the brain. So for lysosomal storage diseases, Batten's disease, for example, and leukodystrophies, there are gene therapy approaches where you inject through multiple injections through the cortex to deliver your gene therapy. In neurotransmitter disorders, which is what we've been talking about today, they are injected more directly to the midbrain structures. So there's been an approach to inject to the putamen, and also to the midbrain that Manju was talking about, to the substantia nigra and VTA. There is other ways to try and treat the brain, and that is by infusing your gene therapy into the CSF space. So that has been done through cisterna magna injection or intrathecal infusions as well. And that's been used for spinal muscular atrophy and Tay-Sachs disease. And depending on your disease target, you may choose to deliver your gene therapy by intravenous infusion. And I think this is probably the most well-known gene therapy in pediatric neurology, is intravenous gene therapy for spinal muscular atrophy. But you may choose to do an intravenous gene therapy for a multi-system disorder. So if you have a lysosomal storage disease that affects the brain and the liver and the heart, there may be an approach to deliver intravenous gene therapy on its own, or intravenous combined with intraparenchymal injection as well. So there's many different approaches of how to deliver your gene therapy, really depending and tailored to the disease you're trying to treat. There have been other trials of subcutaneous and intramuscular injections for neuromuscular disorder. But for neuromuscular disorders, they've really moved away from intramuscular injections and gone on to intravenous infusions. So there are over 40 clinical trials in pediatric neurology for viral gene therapies, and I could spend all day talking to you about them, but I think we'd both be really bored anyway. So if you're interested, we had a recent review out. And I guess the take-home message is there is a huge amount of novel therapy development for rare diseases. And so there's a lot of hope out there for these children. So I'm going to really highlight three key events that have happened in gene therapy field for child neurology. And you guys probably all know about Zolgensma, the most expensive drug in the world. It costs $2.1 million. This has caused a paradigm shift in clinical gene therapy, where they treated children with spinal muscular atrophy type 1 with intravenous AAV9 SMN gene. And essentially, this is one of the first patients they ever treated. She was treated as a newborn, so really very much as early as possible. And she is now age 4, walking and dancing and going to meet Francis Collins, the director of the NIH. So this really shows you the therapeutic potential of gene therapy. This is a recent update of the first patients they treated in the trial. So they have now dosed over 50 patients with spinal muscular atrophy type 1 in the clinical trial. The natural history of this disease, as you're probably all aware, is this group in red here, where they all decline in their chop intent and motor ability, and most have died from respiratory insufficiency by the time they're 2 years. The children treated with gene therapy consistently do not decline and actually trend away. So they're all making great motor improvements and survive beyond 2 years. So they no longer really have spinal muscular atrophy type 1. And of course, this gene therapy has gone on to FDA, regulatory approval all over the world. And I believe you have treated patients in India, which I think is just absolutely amazing. So this is really the potential and the great inspiration about gene therapy for childhood neurological disease. And I think the field really exploded after this. But it's still novel therapy, and there is still lots to learn about gene therapy application. So with that in mind, I just wanted to highlight this gene therapy trial. So they have been incredibly successful in treating neuromuscular disorders with intravenous AAV gene therapies. In 2019, this was a really highlighted gene therapy trial for X-linked myotubular myopathy. So another life-limiting neuromuscular disorder. They had recruited 12 boys that were under 7 years. So this is an older age group than the children in the SMA trial. And it was a dose escalation trial looking at safety and primary efficacy. And they delivered a different type of AAV8 with the AT123 gene therapy. And this was at higher doses than the SMA trial, so a log higher, 1 × 10^14. And their dose escalation was 3 times that. So this is actually really high dose gene therapy. Their preliminary data was astonishing. So all the boys had significant gains in their motor scores, in their chop intent scores. The boys were coming off their ventilators, so their respiratory insufficiency was being treated, and they all showed robust myotubulin expression on their muscle biopsy. But 6 to 9 months later, 3 patients died in this gene therapy trial. So there was clearly therapeutic gains, but something had gone wrong. In this trial, the boys that died, they were the eldest patients, so they were the heaviest children and received the highest dosage, so they were in the highest dose arm. They had all been noted to have some bilirubin dysfunction, so some liver dysfunction before having gene therapy. And this has been noted in X-linked myotubular myopathy boys before. So it's something that has been observed in the natural history of this disease. 3 to 4 weeks after gene therapy, their liver dysfunction deteriorated, and these boys essentially went into liver failure, and they died from liver failure and sepsis. And this has cast a big shadow over the field. And it really means that we still have a lot to learn about these therapies. What we do know about AAVs is it's a virus that is able to infect lots of different cells. And it infects, so if you inject AAV into a mouse and you're targeting the brain and you measure how much AAV ends up in the brain, you'll have 1 copy of AAV per neuron, for example, in the brain. If you look at the gastrocnemius, then you've got 3 copies, so 3 times as much. Same with the heart, there's more in the heart, more in the kidney and the spleen. When you look into the liver, you're getting 40 to 50 copies per liver cell. So a huge amount of AAV, when delivered intravenously, does end up in the liver. And there's a huge amount of work about how we control AAV expression and minimize off-target expression. It's very difficult, especially if you're targeting something like the skeletal muscle, on how to deliver it safely, because you can't literally inject every muscle to deliver the AAV to avoid systemic delivery. So a really safe way to deliver AAV gene therapies is actually to inject it into the brain directly, and that's why I'm going to move on to talk about AADC deficiency, which Mandy's already highlighted. So this is another astonishing clinical trial. So they had developed AADC gene therapy for Parkinson's disease. So we know it's the dopa decarboxylase gene and it converts L-dopa to dopamine. But we also know that there are children with AADC deficiency. And in Taiwan, the population has a founder mutation. So they have many more patients with this disorder than other parts of the world. So the Taiwanese group essentially recruited 4 children to receive AADC gene therapy on a compassionate basis with astonishing effects, really. So this is the AADC patient at baseline, as you can see. As Manju's already highlighted the clinical features of this disorder. They really have very little developmental gains over time, and the natural history is that many have reduced survival and lived to about 7 years in the original studies. This is the patient 6 months after gene therapy. You can see that her nutrition is greatly improved, but she's able to roll over and sit up by herself. She's much more alert, and this patient went on to walk. So this is astonishing. This research group have gone on to treat 20 children with bilateral putamen infusion of AAV2 AADC. And these have ranged from age 3 to 18 years. And they've been followed for 9 to 13 months. They've all shown great improvement in their motor scores, dystonia, swallowing, breathing, and ocular gyrate crises. Something of note is that they have treated a large age range of patients, and the younger patients that were treated, the better their prognosis, the better the response to the gene therapy. So since then, there has actually been a slightly different approach. So a US group have developed a clinical trial where they deliver AAV2 AADC to the midbrain substantia nigra and ventral tegmental areas, so directly to the dopaminergic neurons rather than to the putamen. And they've treated 7 children aged 4 to 9 years, and they've had very promising results as well. So this is their patient that they have published. I don't know why all their patients are Chinese. I promise I'm not just picking Chinese patient videos. So this is the patient at age 8 at baseline. And you can see she has very similar motor disorder to the other patients. This is her now being able to stand up and walk. And she's just made amazing motor progress. And this is her really having a chat with her mum about what foods she likes as well. So all those studies really have been an inspiration to our research group on what we can do for our patients and the patients we've been seeing. So we kind of went on to develop gene therapy for dopamine transporter deficiency syndrome. And how that came about really is, well, Manju met Shannon, one of the first patients diagnosed with dopamine transporter deficiency syndrome. And it's this magical link between patient, doctors, and scientists. I think it's all underpinned by compassion. And with that, you need the know-how and the funding. You kind of need all of those things in place for this to happen. So Manju's already talked to you about dopamine transporter deficiency. She beautifully delineated it. And the patients present with this infantile Parkinsonism dystonia, this hyperkinetic choreic movement disorder. This patient's almost got polysemic movements. And with time, they progress. So this is the same child who has become severely Parkinsonian. She's rigid, stiff, and almost akinetic. It's caused by biallelic loss of function in the SLC6A3 gene and has the characteristic neurotransmitter profile with raised HVA and HIAA. So to date, there's been 28 published cases, but overall we know of about 40 to 50 patients worldwide. And we were so happy to be able to help diagnose some Indian patients recently. Manju's already told you about what happens with loss of function of the dopamine transporter. Essentially, you don't reuptake dopamine, and there's massive of it in the synaptic cleft, leading to that raised and unusual ratio. And this is kind of how we went about developing gene therapy for dopamine transporter deficiency. We biopsied some patients for fibroblasts, and they were converted into induced pluripotent stem cells to develop a midbrain dopaminergic neuronal model to test the gene therapy and some small molecules. From that testing in the patient-derived cell model, we were able to also do in vivo gene therapy in the mouse model of the disease. So this is our recent publication on this work. And this is the beautiful in vitro work from Dr. Serena Barral. So these are the patient derived midbrain dopaminergic neurons that we treated with gene therapy. And what we observed is really that following gene therapy, these are treated new patient neurons, and this is a mock gene therapy, is that after gene therapy, they had lots more neurons. So the neurons were surviving much better. And we also did a dopamine uptake study, and we restored dopamine uptake in the patient neurons. So we had really great proof of principle that gene therapy on the patient neurons would improve survival and restore dopamine transporter function. So we then went on to develop a gene therapy that we thought we could bring to the clinic and test it in mice. So we brought over the dopamine transporter knockout mouse and tested gene therapy in newborn mice. And what happens with the transporter knockout mice is that they are smaller. So these are the body weights in blue of knockout mice. In red are treated with gene therapy, and in black are wild-type mice, normal mice. Following gene therapy, we're able to improve the body weights of treated mice. Normally, that knockout mice have reduced survival, so only about 40% survive after 5 weeks of age. Following gene therapy, all the mice survived to 1 year. So we restored body weight and survival of these mice. We took the brains and looked at where the gene therapy was being expressed following this neonatal brain delivery. And what we found with our AAV9 gene therapy is we were expressing the dopamine transporter incredibly well, but it was throughout the brain when it really should be restricted to the midbrain structures, so the substantia nigra, caudoputamen. We were able to measure the neurotransmitters in the mice, and saw that following gene therapy, we were able to reduce the H3 in the mice. So I'm a bit embarrassed that we have facilities to measure neurotransmitters in mice when the whole world struggles to get these specialist analyses. So we had, again, a really good proof of principle that we could make a gene therapy and show that it was working in the mouse model, but we really needed to refine it. We really needed to refine to make sure it was being expressed in the midbrain and the right and the correct brain regions. So we did the study again in adult dopamine transporter mice and changed the serotype of our AAV to AAV2 that has a much more restricted expression profile than AAV9. So we injected it by stereotactic delivery to dopamine transporter mice at 4 weeks of age. So that's sort of like teenage mice. And we did a dose response. So we did 3 different doses. And what we could see is with the middle and higher doses, we improved survival to a year. And we had some mice die with the lower dosage. And we had control animals that died much earlier. So we're improving survival again in these older treated mice. We looked at the movement of these mice in particular, and these are just traces of how mice move. Wild-type mice, when you video them, they move all over. Knockout mice, so dopamine transporter knockout mice, they just move in circles all the time. So they have this very distinctive pattern. Following gene therapy, you can see that actually the way the mice move are being normalized, but at lowest dosage, they're starting to move in circles again. So this is probably not effective. So we were really pleased that this was having an effect in improving the movement of these mice. And again, we took brain samples to look at where the gene therapy was being expressed. So this is how it should be expressed. So this is endogenous dopamine transporter in the mice, where it's being expressed in the striatum and midbrain. There's nothing in the knockout mice. And we've got a really nice profile of where it's being expressed following gene therapy through this targeted delivery. So a much more physiological way of expressing it. And then we did a lot of neuropathology to make sure the gene therapy appeared safe, and all the neuropathology panels were very clean and really showing very good safety with this method of delivery. So that's really a lot of work and really the future for a novel therapy for dopamine transporter deficiency syndrome. And Manju has been working incredibly hard to progress this really towards clinical trials. So I hope that will be on the cards in, well, not too soon, in a not too distant future. So my general conclusions are that this is a really exciting time for novel therapies for rare disease. If you look at how many AAV gene therapies there are being developed, there are 900 in clinical trial at the moment. 300 of them are for rare disease, so a third of them are for rare disease. Genetic therapies are definitely here to stay. And we probably will need another COVID vaccine in the next 12 months, and that will be interesting. Definitely reach out to the international community about your rare disease patients, because it's very likely that there will be a novel therapy out there for them. This is just a map of the world of where we've most recently diagnosed dopamine transporter deficiency patients. So they are all over the world, and they have reached out to us. I'm really happy that we've helped diagnose some patients in India and Pakistan recently. I think I will end it there because it's been a long evening for everyone.
Thank you very much, Dr. Ongai. I think it was one of the fascinating lectures which I've heard for a long time, and how how gene therapy is at least promising to change the lives of many people in the West, may not be so much in developing countries as yet. Still, shall we start the question answer session, Anne? And how
Just
much time do we have?
Just, no, we just go on, get on with it. I think many of the questions have already been answered.
Yeah, I know, but I'll just go through them.
Yeah, let's please.
Yeah, so I think one of the interesting questions which I see over here is, what is the long-term outcome of these kind of children as they go into adult life? I assume I know it's probably very good for the Segawa syndrome, but for the more severe types, what happens in TH deficiency? Maybe Manju, could you give us, what do you think?
Let me just find my. Can you hear me? I can't seem to.
Yes. You heard my talk,
Yeah.
my question?
Yes, I did. Yeah. Do you know? I don't think there's enough data to know. I think. So what I will say is that I think there's probably lots of undiagnosed patients within the adult services, most definitely, you know, adults who have not been diagnosed and have not been treated, who probably have more severe types. I'm not sure what the long-term treatment outcome is for, you know, the long-term outcome in adulthood for things like tyrosine hydroxylase deficiency, etc. The one thing I will say, I think, even with Sagawa's, when we see the children transition from childhood to adolescent, you know, they just remember the L-DOPA doesn't address the serotonin issue, so we see lots of children with neuropsychiatric presentations, you know, functional overlay of their movement disorders, that sort of thing. But the motor response is excellent, and I think that continues. We know, if you've taken just Sagawa's as an example, that there is thought to be a higher risk of early Parkinson's, as that's been published in the literature. So that's something to watch out for and be vigilant for. The worry with some of the other dopa-responsive dystonias is, will eventually they need to have a dopaminergic agonist replace the L-DOPA? Do they eventually become kind of slightly immune to it, I guess, is the question. But there's not enough data on that yet, I would say. That I think that will only emerge over the next 10 to 15 years.
Okay. There's one more. There's some questions on dosage of you know, levodopa, which I think Manju has answered in her talk. Sangeeta, do you use them differently? What do you use?
We use the same dosage. We start with 1 milligram per kg in divided doses, and we go up to 10 mg per kg per day.
So if you're giving
we don't. Most of them don't require so much of high doses. They settle down with 1 to 3 mg per kg per day.
Right. So if you do not get, for example, if you do not have access to all these tests, and you're giving a levodopa trial, would 10 milligrams per kilo be a high enough dose to confirm that this is probably not helpful, or should we go even higher than that? That's the question.
There are few reports where they've used a very high dose, even up to 20 to 30 mg per kg per day, with a ceiling dose of 300 milligrams per day. But in our practice, we haven't used so much of high dose. Most of them respond to a smaller dose.
Okay.
Yeah, I mean, I'd agree with that. I think for the very true Sagawas, the dominant GCH1 mutation proven Sagawas, I've never had to go above 3 milligrams per kilo per day. That they've had a very good response, and they never get dyskinesias really. I think it's dependent on the condition. I mean, for TH deficiency, I've gone up to 20 milligrams per kilo per day. You know, for some of the other Terran disorders, anywhere between 8 and 15 milligrams per kilo per day, as tolerated. You know, so providing they don't develop gut dyskinesias, you know, gut dysmotility or dyskinesias, then I think, you know, it can be tailored accordingly. But if you've got a child where you're suspecting a dominant Sagawa's, I think if you get to 5 per kilo, it's unlikely it's going to be, you know, without a complete response. It makes it less likely, I'd say.
I think tyrosine hydroxylase in this instance, the incidence of the dyskinesias is so high in some of them that it's really difficult to reach those doses also, right?
It is. So for that, as I say, I would use amantadine. So there's a very nice paper by Rosa Pons's group talking about the use of amantadine for tyrosine hydroxylase deficiency. So if I increment the L-DOPA, and then you get to a stage where disease develop, I would stop at that dosage, introduce amantadine, gradually increase that to 4 to 6 milligrams per kilo in 2 divided doses, and then restart the increment, and it really does help.
Alpa, do you want to ask about that neurotransmitter? How do you, I think, Joanne, maybe it's about how to transport this, what are the precautions you take for the terrains and stuff? So maybe
Yeah, I think she mentioned in her talk. So transporting on dry ice is very important, right, Dr. Kulan, in the frozen state? And then snap cooling, particularly for the terrains. So we need to add an antioxidant also, or only snap cooling is good enough for?
We just snap frozen liquid nitrogen.
That's good enough. Right? Okay. Yeah. Yeah. Thank you.
There's some questions on whole exome sequencing. I think 3 of them, Vivek, Jain from Jaipur, Niru from Bombay, that if you have, whole exome sequencing negative, you haven't done the CSF neurotransmitters, what kind of percentage, what is the yield of NGS and other things in neurotransmitter? I'm sure it's different in different disorders, but in general, what is the yield? And if you have a negative first genetic test, would you still proceed with the CSF neurotransmitter analysis?
I mean, I'm happy to have a go at answering that. I mean, I don't think that we truly know what the yield is, but I think my gut feeling is the yield's pretty high for whole exome. But exactly like Viraj said, it's going to be dependent on the conditions. So for Sagawa's, we know that a proportion of the mutations are copy number variants, that they're kind of deletions or duplications, so they will be missed on whole exome. For tyrosine hydroxylase deficiency, there's a small number of patients that have promoter mutations, so they will be missed on whole exome. I don't know the exact figure. I don't think anyone does know the exact figure, but I suspect it's quite small, the mutations you'll miss. They will be the classical intronic changes, promoter mutations, copy number variants, etc. that will be missed, which will be only a small proportion, and mosaics, I guess, but it'll be small, I think, so you've got a good chance of picking it up. The issue comes with CSF is when you get a variant of uncertain significance. I think Dr. Yoganathan had a very nice case of that with an AADC variant that was classified as a variant of uncertain significance, and that's where your CSF, if you see a very classical AADC picture, plus or minus the AADC enzyme activity, will really help you towards a very definitive diagnosis. So a variant of insignificance that's either grade 3 or 4 will be brought up to 5 by having those adjunct investigations. So that's when they're useful, I think.
There's another interesting question about the secondary neurotransmitter disorders, the one which you showed, this the DIT11 having the cerebral serotonin deficiency. Did you supplement him with 5-hydroxytryptophan?
That's a really good question. In fact, Vivek, thank you. That's a good question. So rather than 5-HT, SSRIs have been tried for these patients because of the prominent neuropsychiatric features, with some anecdotal benefit. But absolutely, I think there's an argument to think about L-DOPA and 5-hydroxytryptophan or the SSRIs in these secondary conditions. We often do for some patients, to see if there is a clinical response to those neurotransmitter abnormalities.
Joanne, I just want to ask you one question on this AAV vectors which you use. I mean, people have antibodies against them. And one of the problems we had with giving Zolgensma was that the antibody titers are high. You can't give them. You can't give it. So what happens what happened? How important is this problem, and does it apply, for example, in these vaccines which are using the COVID vaccines?
So it is important because essentially we are delivering a virus, and your gene therapy will not be effective if you have an immune response to it. So you will exclude patients from receiving gene therapy if they have pre-existing immunity. So you're probably aware that lots of gene therapy protocols have some degree of conditioning to try and minimize the immune response. So that could be steroid steroid regimens, and some have even more immunosuppressive regimens like cyclophosphamide or mycophenolate as well. There are lots of research groups developing AAV serotypes that evade the immune response to make them applicable to patients with pre-existing antibodies, but also to consider for redosing, so to redose the patients as well. In terms of COVID vaccines, they're different technologies, so they're not, so for the mRNAs, it's not of particular significance. I don't think we know enough really about the mRNA vaccines, about the immune response, because you can have an immune response to the DNA, the foreign DNA itself, or to the foreign mRNA within the gene therapy. With the adeno-based gene therapies, there clearly has been unusual immune responses. So you're thinking about the unusual response with the VIPs, the vaccine-induced thrombocytopenia and thromboses events. There's lots to be learned about these vaccines and immune responses to viral vectors.
A few questions on ADC. One was an interesting question. I mean, Umesh from Pune has asked about treatment of ptosis. I'm assuming this is a sympathetic denervation kind of ptosis, Horner syndrome kind of thing, right? Which happens in AADC. And he's asked whether you can use some medications to help that.
So in my experience, it's a really good question, Umesh, but I don't find that the ptosis has any functional issues for the children, really, you know, that so I've never tried pyridostigmine. Some of them who are responsive to dopaminergic agents, you do see an improvement when you start something like bromocriptine or selegiline or something, you know, if you try those. I certainly haven't treated the ptosis per se because it doesn't lead to any, the patients I have, you have a mild to moderate ptosis and it doesn't affect visual function. The one thing I've really noticed is I've had about 5 children who are now post-gene therapy that the ptosis improves post-gene therapy.
About dopamine agonists, which ones do you, I think you already mentioned that, but Sangeeta, Manju, and anybody in ADC, dopamine agonists, iroperenol or pramipexole, what is your experience? Any sort of, you said bromocriptine, according to you, seems to be the best one, right?
I'm interested to see what Sangeeta says, but my personal, I find pramipexole quite difficult in the under ones to tolerate. They just don't seem to, they have terrible gut issues from it. So I tend to use bromocriptine in the early stages with quite close cardiac monitoring to look for, you know, kind of cardiac fibrosis, pulmonary fibrosis and things. So they have echoes quite frequently if they don't tolerate something like pramipexole first. And as they get older, then I might switch them onto a rotigotine patch because it stops the on-off phenomena that you sometimes see with these children. I don't know whether Sangeeta has.
We have quite a few patients with amino acid decarboxylase deficiency. Like they respond well to selegiline. We haven't tried pramipexole or bromocriptine on them, but they do well with the selegiline.
So, yeah.
But selegiline, would you use it as a? I mean, you would use it more in the to sort of enhance the response or prolong the response of the dopa. Am I right?
Yes, it's an MAO inhibitor basically. So it increases it inhibits the degradation of.
Right, that's right. That's right.
So I would start, and my order would definitely be the pyridoxal phosphate first to try and help any residual AADC enzyme activity, and then exactly like Dr. Yoganathan said, that I would add a selegiline next. Selegiline or tronalsopramine would be the common ones we use in the UK as the second line, and then the dopamine agonist after that if needed.
That's 3 ways. Okay. I think one more question on neurotransmitter. Besides clinical response, do you use the neurotransmitter metabolites in the CSF as a guide to your therapy?
Monitoring basically.
Yeah, basically monitoring, yes. I mean, we don't do it often over here because it's difficult to do. But what about you guys? Do you do it in the UK? When you
I mean,
have a,
so there's certain conditions I would not do it for. So things like AADC deficiency does not need monitoring because you're not going to change it with your management. And dopamine transporter deficiency, I wouldn't do it for. But I do it for some of the pterin disorders because I think it can help, you know, knowing what the CSF HVA is like on treatment and things. I've certainly had it help when there's families who are non-compliant with treatment because you can clearly see the absence of a 3-O-methyl dopa peak. So then you know they're not giving the medication and that's why the HVA is low. So if I'm worried about non-compliance for the conditions where I'm giving L-DOPA, where there's long-term kind of developmental trajectory monitoring, you know, so the pterin disorders apart from Sagawa's and so PTPS and DHPR and SR and tyrosine hydroxylase I do for the first couple of years of life and then after that I would do it less frequently.
Alpa, any questions you have or anything? No?
Let's check, so.
Let me ask you a
This-
question of one till then. I'll ask one of the things is always, I've always wondered, paroxysmal tonic upgaze of infancy. Is there any sort of transient neurotransmitter disorder which happens, deficiency, which is sort of in infants? Is
It's
there
a
any?
good question. I don't know. I mean, they must be part of a continuum, mustn't they? You know, the
Because there have been reports that levodopa helps it.
yes, yeah. I mean, who knows what the ocular gyrate crisis basis is? Is it some dopamine deficiency within the brainstem? I wonder, you know, but it wouldn't surprise me if those, I mean, I guess paroxysmal tonic upgaze is also thought to be slightly brainstem you know, kind of origin, you know, so it may be that it may be dopamine related, it may be that L-DOPA helps. I don't think people know enough about those two phenomena really. Certainly, I think what's really powerful is looking at the AADC children who have had gene therapy and before that would have had very, very long ocular gyrate crises. The fact that they've disappeared suggests that dopamine replenishment is part of the pathogenesis of that particular symptom.
Mimi from Kerala has asked about your experience with GNAO mutation-related movement disorders.
Yeah, I mean that's a whole other talk, I guess, in itself. But I mean, we look after patients with GNAO1 mutations. We've got quite a big cohort. There's the classical phenotype where you may have early onset developmental delay and seizures. Some of them have quite marked epileptic encephalopathy. Some are milder seizures, and then the development of often paroxysmal movement disorder with these hyperkinetic status hyperkineticus kind of episodes that often require admission into PICU, etc. I'm not really sure what her question was related to the movement disorders. That's the kind of pattern we see. There's also an atypical phenotype we've recently identified that are more like some of the primary dystonias with lots of speech dysarthria and kind of more of a dystonic phenotype. So that's the kind of spectrum that we see. And I'm sure Minnie knows well that the drugs that I find work, a tetrabenazine is particularly good for those exacerbations, and then deep brain stimulation really can help get rid of them completely. Is that what Minnie was after? I'm not really sure.
Murugan has asked about, Joe, can you tell us about gene therapy techniques in wider neurological conditions? Is there any hope in that? It's a very general question, but what is your sense? I mean, not just in these rare disorders where talking of, I suppose,
Yeah.
you know.
So there's a lot of work in neurodegenerative gene therapies, so specifically in movement disorders, so Parkinson's and Huntington's. So there have been I think about 200 patients that have had gene therapy in a Parkinson's clinical trial. The difficulties with that disorder is really that the etiology of Parkinson's is still unknown. So the gene therapies being developed are approaches to improve neuronal survival, so neurotrophic factors, or for dopamine synthesis enzymes, so like ADC or a combination of those. The early clinical trials showed safety in these gene therapies, so they've shown and some level of efficacy, but they haven't really shown superior efficacy to say, levodopa or deep brain stimulation. So there's a lot of work that needs to be done, really looking at the delivery and dosing and the timing of when you give these gene therapies. So I probably didn't highlight how important it is, the therapeutic window of giving your gene therapy. So in the SMA type 1 recent review, all those patients did incredibly well, but one child that was dosed just under 8 months responded least well. So the longer you leave it, the less effective the gene therapy is. So in these adult disorders, especially like Parkinson's, these patients have already had a huge amount of neurodegeneration. It's very difficult to know when that therapeutic window is. So there's a lot of work to be done. Definitely in the pediatric population, we really need to be diagnosing these patients as early as possible and giving them gene therapy as early as possible. In the ADC deficiency trials, where they've treated children up to 18 years, the children that did best were the ones that treated age 3, 4, 5 years old. So I'm all up for newborn screening.
And if you could just touch upon, I mean, this is my own, I want to ask you this about CRISPR-Cas, what is going to be the future in pediatric neurology, because you mentioned a lot of side effects as well, and what do you think? For example, I think recently there was an article in amyloidosis where they used CRISPR-Cas. Yes.
So I think CRISPR-Cas is really exciting. The main thing is the efficacy and off-target effects of CRISPR-Cas9. So that's precision genome editing, and is technically more complex than gene supplementation. And it will be really important for heterozygous disease. If you're thinking about like epilepsies, where there's a gain of function mutation, that sort of thing.
Yeah.
The problem is that patients all have different mutations.
Yes.
So you can't actually develop one gene therapy per patient. That's not feasible, not yet anyway. But I think it's definitely something to be very excited about, because the current clinical gene therapies are really reaching the clinic are for monogenic loss of function.
Right. Absolutely. Yes. I think
so there's one question from Shruti Agarwal. She wants to know that since genetic tests are costly, are there any clinical markers to select whole genome over versus whole exome sequencing in neurotransmitter disorders? Dr. Kurian? Any clinical markers to select whole genome versus whole exome?
I think that's a really good question. So in the UK, we're definitely moving towards whole genome sequencing just because of what you can do with the data. The data can be interrogated for copy number variants and intronic changes. I don't have a feel of what further kind of yield you'll get, and there's certainly nothing clinically that would point to a splice site or a deletion. I don't think there's anything that would make me want to kind of that's known currently. Perhaps when more whole genome data is available for these children, to see which ones are missed, we'll have better answer for that. But I think right now there's not anything, no particular clinical kind of things that you will then direct you to either whole exome or whole genome.
There's another question from Dr. Sumita. She says, how often do you refer your patients to psychiatrists for behavioral problems?
Quite a lot. I do, but it's for more. It's for more it depends on the condition really, that but you'll all know that there's a big correlation between movement disorders and neuropsychiatric symptoms, whatever the underlying cause of the movement disorder is, but particularly for the neurotransmitter disorders. And I do wonder whether some of it's related to the serotonin kind of phenotypes. What's interesting is in some of the AADC children that have had gene therapy, the ones I look after, that their kind of motor resolution improvements have kind of almost kind of shown up lots of underlying neuropsychiatric things for them. So anxiety, frustration, behavioral things, because with the gene therapy available, it's not targeting the serotonin pathways, it's just targeting the dopaminergic pathways, but the conditions that really jump out at me are sepiapterin reductase deficiency. We've seen lots of children and young adults that have quite marked neuropsychiatric disturbance from that, but also AADC deficiency and some of the others. So I would involve, in the UK, we have a CAMS team, so child and adolescent mental health services, quite early for these conditions, so they're supported. And if I was to trial an SSRI, for example, I would definitely do it with a consultant psychiatrist by my side.
Any more questions we missed, Alpa? I've gone through many of them, but
No, so I think there was one question on Dr. Ang regarding the gene therapy in mitochondrial disorders. I think somebody's asked that question. I just saw it somewhere. So Dr. Young, any?
Yeah, there are preclinical gene therapies for mitochondrial disorders. I think they're mainly for the the nuclear genes, though I'm not sure about the mitochondrial genome ones. So we're doing one here in our lab, but I think that's all I can tell you about it. They are being developed, and we're looking at one disorder in our lab.
one more question on gene panels for NTD, neurotransmitter disorder specific gene panels. Do you have that in Britain?
So all the neurotransmitter genes are incorporated into a movement disorder panel.
Yeah, I think we've covered practically all the questions.
I think this has been a fascinating session. I think it was. I really appreciate all of your superb talks, and I hope too that you can again come. The next time you come to India, and we'll have a personal meeting, one of our conferences. Hope all of you do. Thank you very much for this lovely session. Thank you.
Yeah, thank you for the excellent talks. Thanks a lot.
Thank you. Thank you for having us.
Rani, can I have a word?
Yes.
So thank you to all our wonderful speakers. Firstly, thank you so much to ORDI who have made it possible for this to happen. Thank you to Dr. Sangeeta, Professor Manju Kurian, Dr. Joanna, and to our moderators. Dr. Manju, this is exciting times for us, looking at both what you and Dr. Joanna have done, but also in the fact that things are happening at an unexplained rate, as you rightly said, with regards to the explosion of things, explosion of all the new discoveries. But also for us, I work in a very small hospital, but even in that small hospital, we are now beginning to have subspecialties in neurology, which we never had in India. So to the effect that January, we started our first gene therapy. We've got 8 children on gene therapy in SMA. We've got 46 children on therapies for neuromuscular disorders. So even the more number of people like Dr. Sangeeta, who's doing more on movement disorders, we're just going to see amazing possibilities. So I think India is neither Africa nor Western country. So we may find many ways of possibilities happening, creative ways of happening. So I think this will be really good. Thank you so much for coming today. And thank you to all of you.
Thank you.
Thank you very much.
Thank you, everyone. Yeah. Bye.
Thank you.
All the best.